Good morning, ma'am, and my dear friends. I, Aidaphishisha Hayong, rule number 1, first year post basic BSc nursing. Today I'm going to do a demonstration on tracheostomy care and suctioning. Let's see what are the parts of the tracheostomy tube. First one will go with the outer cannula, and outer cannula is the tube that sits in the trachea. There are different sizes of outer cannulas. Flanks are the curved wings on each side of the tracheostomy tube. The flanks can be connected to the tracheostomy ties to hold the tracheostomy tube in place. Tracheostomy ties goes around the neck and help keep the tracheostomy tube in place. A cuff filled with air helps hold the tube in the airway. We may see a thin tube hanging from the outer cannula. Air can be inserted or removed from the cuff through this tube. The tracheostomy tube may not have a cuff. An inner cannula is a smaller tube that sits inside the outer cannula. The inner cannula can be removed for cleaning. There are different sizes of inner cannulas. The tracheostomy tube may not have an inner cannula. An obturator is a small device used to insert a new tracheostomy tube. A speaking valve is a cap that fits over the opening of the tracheostomy tube. There are many different types of speaking valve. As we can see in this photo, is a patient with a tracheostomy tube. Before going with the procedure, so we'll see first what is the definition of the tracheostomy care. Tracheostomy care includes changing a tracheostomy inner tube, cleaning tracheostomy site, and changing dressing around the site. Tracheostomy care is done to keep the tracheostomy tube clean. This helps prevent a clogged tube and decrease the risk for infection. Tracheostomy care includes suctioning and cleaning parts of the tube and the skin. Now we'll see what the purpose of tracheostomy care. First one, it is to maintain airway patency. 2, to prevent infection at the tracheostomy site. 3, to facilitate healing and prevent skin excoriation around the tracheostomy site. 4, to promote comfort for the patient. And 5, to assess condition of ostomy. Now we'll see within the indication. First one is to maintain a patent airway. Bypass upper airway obstruction due to foreign bodies, traumatic injuries, vocal cord paralysis, surgical edema, tumor, burns. Second one, to facilitate removal of secretion. In case like severe bronchitis in a defibrillated patient, neuromuscular disease, paralysis of chest muscles and diaphragm. Third one, permit long-term positive pressure ventilation. Massive chest wall trauma, respiratory failure, high lesion, spinal cord injury, prolonged coma, neuromuscular disease. Fourth one, to prevent aspiration of gastric content and in prolonged unconsciousness. Fifth, lung or airway or breathing center anomalies secondary to congenital defects. 6. Improve patient comfort due to absence of endotracheal tube. Enables eating, speaking, increase mobility due to tube security. In general, if extubation not possible, tracheostomy performed after 7 to 10 days for long-term ventilation. Now we'll see with the types of tube. First, we have metal or plastic. Second, single cannula or double cannula. We have cuff and uncuff. Fenestrated for speaking and non-fenestrated. Fifth, disposable and permanent. 6. Long-term and short-term. So now we'll see what are the equipment needed for tracheostomy care. In tracheostomy care, we need to have 2 trays. The first one we can keep the tracheostomy care kit, and the next tray we can have a clean tray. Now we'll see with the tracheostomy care kit. We need to have 3 gallipods, a sterile towel, a sterile nylon brush or tube brush, a sterile gauze square, a cotton twill ties or tracheostomy tie tape, a sterile bowl for solution. Now we'll see with the second tray. A clean tray containing a sterile suction catheter, hydrogen peroxide, normal saline, sterile gloves 2 pair, clean scissor, face mask and eye shield. This is optional. K basin, waterproof pad and suction apparatus. Now we'll see with the procedure. The first one, we have to assess the condition of stomach for any signs of infection. Redness, swelling, character of secretion, presence of purulent or bleeding. Presence of any of these indicates infection and tests may be warranted. Next, we have to examine the neck for subcutaneous emphysema evidenced by crepitus around the ostomy site. If crepitus is present, it indicates air leak into subcutaneous tissue. Next, explain the procedure to the patient and teach means of communication such as eye blinking or raising a finger to indicate pain or distress. We have to explain the procedure to the patient in order to obtain cooperation from the patient. Next, assess patient to a Fowler's position and place waterproof pad on chest in order to promote lung expansion and prevent soiling of the linens. Next, we have to wash hand thoroughly in order to prevent for cross-infection. Next, we have to assemble equipments, open the sterile tracheostomy kit and pour hydrogen peroxide and sterile normal saline in separate gallipots. Hydrogen peroxide and saline remove medicrus which promote bacterial growth. Open other sterile supplies as needed, including sterile applicator, suction kit and tracheostomy care kit or dressing kit. It enhances performance phase of procedure. Next, put on face mask and eye shield in order to protect the nurse. Next, we have to put on sterile gloves, place sterile towel on patient chest in order to maintain a sterile aseptic technique. Next, suction the full length of tracheostomy tube and pharynx thoroughly in order to remove secretion. Next, rinse the suction catheter and discard it. Next, unlock the inner cannula and remove it by gently pulling it out towards you in line with its curvature. Place the inner cannula in the bowl with hydrogen peroxide solution. Hydrogen peroxide moisten and loosen dried secretion. Next, remove the soiled tracheostomy dressing and discard the dressing and the gloves. Next, put on a second pair of sterile gloves. Next, clean the flank of the tube using sterile applicators or gauze moistened with hydrogen peroxide and then with normal saline. Use each applicator once only. Using the applicator or gauze once only avoids contaminating a clean area with a soiled gauze. Next, clean the stoma area with gauze. Make only a single sweep with each gauze sponge before discarding. House strength hydrogen peroxide mixed with normal saline may be used. Hydrogen peroxide helps to loosen dry crusted secretion. Thoroughly cleanse area using gauze square moistened with sterile normal saline. Hydrogen peroxide is irritating to the skin and inhibits healing if not removed thoroughly. Next, dry the stoma with dry sterile gauze. An infected wound may be cleaned with gauze saturated with an antiseptic solution and then dried. A thin layer of antibiotic ointment may be applied to the stoma with a cotton swab. It helps to prevent wound infection. Next, cleaning the inner cannula. First, we have to remove the inner cannula from the soaking solution. Clean the lumen and entire cannula thoroughly using the brush. After cleaning the lumen and the entire cannula, we have to rinse the clean cannula by rinsing it with sterile normal saline. Agitating the cannula in the container with saline cleans it well. Thorough rinsing is important to remove hydrogen peroxide from inner cannula. Next, we have to gently tap the cannula against the inside of the sterile saline container after rinsing, in order to remove the solution adhering on the cannula. Next, replace the inner cannula and secure it in place. Insert the inner cannula by grasping the outer flank and pushing in the direction of its curvature. Lock the cannula in place by turning the lock into position. This secures the flank of the inner cannula to the outer cannula. Next, we have to apply sterile dressing. Open and refold a gauze dressing into a V shape and place under the flank of the tracheostomy tube. Do not cut gauze piece. Avoid using cotton-filled gauze. Cotton or gauze fiber can be aspirated by the patient, potentially creating a tracheal abscess. Ensure that the tracheostomy tube is securely supported while applying dressing. Excessive movement of the tracheostomy tube irritates the trachea. Next, change the tracheostomy ties. First, leave the soiled tape in place until the new one is applied. Leaving tape in place, ensure that tubes will not expel if patient cough or move. Next, cut a piece of tape that is twice the neck circumference plus 10 cm. Cut the ends of tape diagonally. This action provides a secure attachment with knots. Diagonal cut facilitates insertion of tape into opening of neck plate. Next, apply the new tape. First, we have to grab slit ends of clean tape and pull it through opening on one side of the tracheostomy tube. Pull the other end of the tape securely through the slit end of the tracheostomy tube on the other side. Tie the tape at the side of the neck in a square knot. Alternate knot from inside to side each time tapes are changed, in order to prevent irritation and aids in rotation of pressure side. Ties should be tight enough to keep tube securely in the stomach and loose enough to permit two fingers to fit between the tape and neck. Excessive tightness compress jugular vein, decrease blood circulation to the skin, and result in discomfort for patient. And then we can remove the old tape carefully. Next, leave the patient in a comfortable position to promote comfort to the patient. Next, we have to clear and clean all the equipment that have been used for the tracheostomy care. Next, after cleaning all the equipment, we have to wash and dry our hands. Next, document the procedure, including observation of the stomach. Example for the presence of irritation, redness, edema, subcutaneous air, as well as character of secretion like the color or any purulence. Now we'll go with the suctioning procedure. As you can see in the photo, is the patient undergoing suctioning. Now we'll come to the next procedure, that is suctioning. So we'll see first with the definition. Suctioning is the removal of thick mucus and secretion from the trachea and lower airway that cannot be cleared by coughing. Suctioning is the mechanical aspiration of pulmonary secretion from a patient with an artificial airway in place. Suction is used to clear retained or excessive lower respiratory tract secretion in patients who are unable to do so effectively for themselves. Now we'll see with the purpose. First, to maintain a patent airway by removing secretion. Second, to prevent lower respiratory tract infection from retained secretion. Third, to facilitate patient comfort by removal of accumulated secretion. Fourth, to increase respiratory efficiency. Fifth, to decrease the risk of complete airway obstruction with secretion and decrease the risk of infection. Now we'll see with the indication for suctioning. Suctioning is required when, first, patient is unable to clear secretion by coughing. Second, when there is mucus bubbling in tracheostomy tube. Third, when there is a gargle sound heard on auscultation. Fourth, when there is a trouble in breathing. Fifth, when there is restlessness and on patient request. Next, when there is low oxygen saturation and cyanosis. Next, when there is a stridor or change in breathing sound. Before going to the procedure, we'll see first what are the articles needed for suctioning. In suctioning, we have to have two trays. The first tray, we have a clean tray and a sterile tray. Now we'll see first what are the articles needed to be kept in a clean tray. A clean tray containing a sterile suction catheter with cover. For adult, we can have a number 12 to 16 French gauze, and for a child, we can have a number 8 to 10 French gauze. Next, we can have a sterile water, normal saline in a container, a sterile gloves, a mask, a face shield, a gown, a kidney tray, alcohol swabs, and a stethoscope. Next, we will see what are the articles needed to be kept in a sterile tray. A sterile tray containing a sterile towel, a bowl, and a gauze piece. There are also additional articles that are needed for the suctioning procedure. The first one are a resuscitation bag with a reservoir connected to 100% oxygen source. Next, we can have a suction source. It can either be a portable suction machine or a wall suction unit. So now we'll come to the procedure. First, we have to assess the depth and rate of respiration, auscultate breath sound, monitor heart rate if patient is on continuous cardiac monitoring. If arterial blood gas are done routinely, check the baseline value in order to determine the need for suctioning. Next, we have to explain the procedure to the patient and what the patient should be expecting during the procedure if the patient is conscious. But if the patient is unconscious, we can explain it to the relative. Thorough explanation lessens patient anxiety and promotes cooperation. Next, assess the patient to a comfortable position. If the patient is conscious, we can keep him in a semi-fowler's or a fowler's position. If the patient is unconscious, we should place it in a lateral position and facing towards us. In sitting position, it helps patient to cough and breathe more easily. The position also uses gravity to aid in the insertion of catheter. Lateral position prevents the airway from becoming obstructed and promotes drainage of secretion. Next, assemble equipment and check for the function of suction apparatus and manual resuscitation bag connected to 100% oxygen sources. Make sure that all equipment are functional and sterile technique is instituted to prevent for infection. Use of 100% oxygen will help to prevent hypoxia. Next, wear mask and wash hands thoroughly in order to prevent for infection. Next, open a sterile tray, Take the towel and place in a bib-like fashion on patient's chest. Open alcohol swab and place on corner of towel. Next, open a sterile catheter pack and place catheter into sterile tray. Fill the bowl with sterile water. Next, if the patient is on mechanical ventilator, make sure that disconnection of ventilator attachment may be made with one hand. Next, put on sterile gloves. Designate one hand as clean hand for disconnecting, bagging, and working the suction control. Usually, the dominant hand is kept sterile and will be used to thread the suction catheter. The hand designated as sterile must remain uncontaminated so organisms are not introduced into the lungs. The other glove's hand protects the nurse from infection. Next, connect the suction catheter to the suction source. Next, using clean hand, disconnect the patient from ventilator, CPAP device, or other oxygen sources. Place the ventilator connector on the sterile towel and flip a corner of the towel over the connection to prevent fluid from spraying to the area. This can be done in order to prevent contamination of the connection. Next, ventilate and oxygenate the patient with the resuscitation bag. Compressing firmly and as completely as possible, approximately 4 to 5 times with clean hand. In a spontaneous breathing patient, coordinates manual ventilation with the patient's own respiratory effort. Ventilation before suctioning helps to prevent hypoxia. Attempting to ventilate against the patient's own respiratory effort may result in high airway pressure, predisposing the patient to barotrauma. Next, lubricate the catheter by dipping it into the container of sterile saline or water. This can be done except for silicone catheter. Lubrication promotes easy insertion. Silicone catheters do not require lubrication. Next, we have to turn on suction source with clean hand. Next, pinch the catheter if there is no Y port and insert it in tracheal or endotracheal tube. Insert the catheter about 12.5 cm, that is 5 inch for adults, less for children, or until the patient cough or you feel resistance. Using suction while inserting catheter can cause trauma to mucosa and remove oxygen from the respiratory tract. Resistance usually means that the catheter tip has reached the carina. If resistance is felt, the catheter should be withdrawn 1 to 2 cm before applying suction. Next, apply suction by releasing thumb from Y port or by releasing the pinch on the catheter. Gently rotate catheter with thumb and index finger of sterile gloves hand as catheter is being withdrawn. Turning the catheter while withdrawing helps clean surface of respiratory tract and prevents injury to tracheal mucosa. Apply suction for only a maximum of 10 seconds. Hyperventilate 3 to 5 times before suctioning or encourage patient to cough and deep breathe between suctioning. Suctioning for longer than 10 seconds may result in hypoxia. Hyperventilation reoxygenated the lungs. Rinse catheter between suction by inserting tips in cup of sterile water and apply suction. Flushing cleans and clear catheter and lubricates it for next insertion. Repeat suctioning as needed and according to patient's tolerance of procedure. Allow patient to take rest at least for 1 minute between suctioning and replace oxygen delivery setup if necessary. No more than 4 suction passes should be made per suctioning episode. Allowing time interval and replacing oxygen delivery setup helps compensate for hypoxia induced by the previous suctioning. Irritation from multiple suctioning results in an increased amount of secretions. When the airway becomes clear, return the patient to the ventilator or apply CPAP or other oxygen delivery device. Suction oral secretion from the oropharynx to remove accumulated oral secretions. Next, when the procedure is completed, turn off suction and disconnect catheter from suction tubing. Remove gloves inside out and dispose of gloves and catheter in proper receptacle to prevent transmission of microorganisms. Next, we have to replace the articles, clean ambu bag and mask with alcohol, cover with sterile gloves or sterile gauze and wash hands. Next, we have to position the patient comfortably. Auscultate our lungs area. Auscultation helps to determine whether respiratory passageways are cleared of secretion. Next, record the time of suctioning and nature and amount of secretion. Also note the character of patient respiration before and after suctioning. Provides accurate documentation and provides for comprehensive care. Bibliography. First one is Jacob Anneman, R. Rekha, Clinical Nursing Procedure, The Art of Nursing Practice, 2nd edition, published by J.P. The second book is Francis Celestina, Mishra Critica, Fundamental of Nursing, 2nd edition, published by Latas. Now I have come to an end for my demonstration. I hope you are all clear with my demonstration procedure. So I would like to thank Ma'am Estakar for her support and guidance throughout my preparation for my demonstration. And I would like to thank you friends for your active participation. Thank you.